Thank you, Debbie. Thank y'all very much for the great turnout. This is probably one of the better turnouts I've had at these meetings, so I'm really happy that all you guys got here, and I'm really interested to hear everybody's questions at the end, because that's usually where we get a lot of our benefits from listening to the patient stories, so we can get into some different topics too as well, and kind of learn some additional things. I appreciate the opportunity. I am a vascular surgeon, one of the private practice guys here in town, and I work at the Vascular Institute of Birmingham with two other partners, Drs. David Whitley and Will Harvey. You guys, some of you guys might have seen them or heard of them at least. And we're three of the vascular surgeons in town. We cover Brookwood, we also cover St. Vincent's, and a little bit of St. Vincent's East too as well. I'm going to speak this morning and a little bit into the afternoon on kind of what I do and what our bread and butter is as vascular surgeons. That's one of the things I kind of wanted to explain is, well, what in the world do we really do as vascular surgeons? When I got into residency, my wife and I got married, second year of residency, and when it got to the point where I had to decide what I wanted to do with my life, I really had no idea. I thought I wanted to do trauma surgery, then I thought I wanted to do cancer surgery, but somewhere around third year out of 5 of residency, I decided I wanted to do vascular surgery. My wife is like, what in the world is that? So we go through fellowship, and I think she's still trying to figure out exactly what we do. We spend a lot of time working on our patients, and I think she's still trying to figure that out. So this is also a good lecture that she likes to hear as well, because it explains what we do throughout the day and the types of patients we take care of and what things we can offer for our patients. So we are going to speak about blood clots. That's a very generalized term, and it's a little misleading at times, and we're going to talk about a little bit of the differences in what are we talking about when we say a blood clot. It might mean something different to you than it does to me, and we're going to get into those differences to give you a little better insight as to what it is we're looking for at vascular surgeons and what we can do to help out with blood clots. And a lot of our complaints that we get is, hey, what's wrong with my leg? It's hurting, it's swelling, it's painful, it's sore, there's a wound on it. Is this a blood clot? Is it not? And that's what we're going to kind of discuss here this morning. And again, I can't wait to hear all your questions towards the end. Just a little bit about me to start off with. Who am I? Not just some stranger. I came from Montgomery, Alabama, so I'm a good old redneck, just like probably most everybody in here. Went to Auburn University, Montgomery for the first year, decided I wanted to play baseball, played there for a year, but then really couldn't live in Montgomery anymore, so I decided to go to Alabama. I'm an Alabama fan, but I do have Auburn and Alabama on there, so trying not to offend anybody here today. It probably upset my dad more than anything that I went to Auburn, but that's okay. Went to Alabama, decided to try to play there, did organic chemistry. That got to be a little too difficult and decided I couldn't do both, so I wound up concentrating on organic and then went to med school at UAB. Been here at UAB since really 2000, started med school in 2000, 4 years of that, 5 years of general surgery residency at UAB, and then did 2 years of subspecialization in vascular surgery after that. So 11 years total after college, which about put my wife through the ringer, I think, more than anything. But now graduated, finished in 2011, have been out in private practice since 2011. There's one of our pride and joys right there. He's our 4-year-old, will be 5 in May, that's Braxton. He loves to get the pictures every day of what all we're doing surgery-wise and what all we're seeing. He knows more about blood vessels probably than myself or my wife, really. And then these are our 2 other pride and joys. They were born a couple of years ago, Cole and Caleb, are twins. And they're doing good now, too. They just turned 2 a couple of weeks ago. And they're all the men getting ready for church a couple of Sundays ago. We go to Briarwood. And so they're learning exactly how to do things. They look all nice and dressed up, but it's like a prison riot every day, so don't think it's that much fun. It's a prison riot. So when we talk about vascular surgery, we're going to get into the meat of things here and what we're talking about with blood clots. Well, there are a lot of different things that vascular surgeons do, and again, my wife had no idea, so this kind of explained things to her. We deal, and we'll talk a little bit about the anatomy, but there are 2 different situations and 2 different portions that we look at. There's an arterial component and there's a venous component. If you look at the heart, the blood vessels that come away from the heart and bring blood flow towards the extremities and towards the belly cavity, the intestines, etc., are arteries. They're very much in different structure than the veins. The veins bring blood flow back up from the from the feet, from the extremities, and go back to the heart. They're very different in function, and you can have lots of different pathology with regards to the treatment and to the different types of problems that you have. So there's a lot of different things that we deal with, and you can have blood clots, quote-unquote blood clots, in any of these types of systems, arterial or venous. They present different ways depending on where the blood clot is and what the problem is and what the underlying pathophysiology is. But from the blood flow coming out of the heart, we deal with lots of different types of blockages of the blood vessels, of the carotid arteries that can cause stroke that we have to repair. The majority of it is lower extremity occlusive disease, your run-of-the-mill peripheral arterial disease, where you have blockages in the lower extremities that cause pain when you're walking, Swelling can cause ulcers and can be a very extreme problem that can put a real big burden on the healthcare system and eventually lead to amputations or other different types of problems. We deal with aneurysms as well. That's one of the fun things that we get to do. Maybe I can come back and talk with you about that at some point. These are bulges in the blood vessels that can cause problems too as well, including rupture, and then different other types of things that are a little more complex. On the vein side, and we'll get into this a good bit too as well, because this is more the tried and true blood clot when we talk about blood clots and patients come into the clinic with pain, swelling, or fever, things like that. When they say, I think I have a blood clot, usually it's on the venous aspect, and this is usually of the lower extremities that we see it more than anything. Can cause varicose veins, which we'll mention briefly, can cause a couple of other problems. The big one, and the one that we'll really talk about, is DVT, or deep venous thrombosis. And that's a big blood clot in the lower extremity veins of the leg that can break off, migrate places, go to the lung, go to different other places, and can cause quite a catastrophic problem that can be life-threatening. And again, it's a very difficult problem to treat, and it really requires a lot of healthcare dollars to help treat DVT, so we will talk about that a good bit. Other things that we take care of, again, just wound care, amputations. We deal with dialysis access, limb swelling, which is lymphedema, and other arteriovenous anomalies. To kind of get an idea, again, of what the treatments are for blood clots and what we do, you kind of have to take a background as to how did we get to where we are today in 2014, and this is one of the cool things that I think, and I really like looking at it. We won't do it too long, but just to know a little bit of the history of how did we get to where we are in vascular surgery and our treatments currently. You know, initially, from Ambrose Paré in the 16th century, a Frenchman, battlefield medicine was if it's bleeding, you ligate it, and you close it off, tie it off the best you can with whatever you can do. His quote that he gets credited for is, I bandaged him and God healed him. Well, a lot of people lost limbs this way due to gangrene, due to infection, et cetera, et cetera. So it really wasn't that advanced, but it was the only thing they had. We get to an anatomist and a scientist in the 18th century England, John Hunter, who treated popliteal aneurysms. These are aneurysms behind the knee that swelled and enlarged. There were a lot of infectious issues with that. It was actually from syphilis more than anything. Uncontrolled syphilis would cause these aneurysms, and especially in coachmen with their legs bent, riding the carriage, they would get wear and tear of the popliteal artery and cause large aneurysms there. That can cause blood clots that break off, go down the leg, and can cause a very ischemic, or meaning acutely loss of blood flow to the lower extremity that can be limb-threatening. It was limb-threatening in John Hunter's time, and again, he recommended ligation at that point too as well, and that usually just meant amputation, either above or below the knee. So we still hadn't made much progress from the 16th to the 18th century. We now get into the 20th century, so it still was quite some time, but Alexis Carrel was one of the fathers and the pioneers of vascular suturing technique as to how we tie blood vessels together to treat blockages from blood clots or other types of issues, and he's one of the pioneers. We still use patches called Carrel patches that are ways that we can sew vessels together to help bypass around blockages. And then some of our Southern history too as well. Tulane graduate Rudolph Mattis, who is on the cover of the Southern Association of Vascular Surgery, is one of the fathers again of modern aneurysm repair, and he was from New Orleans, and a nice Southern gentleman that helped continue to advance the field of vascular surgery. All the way now to Michael DeBakey, and some of you might be familiar with his work in Houston or have heard the name at least. Again, in the 1950s, he's the first one that kind of pioneered with the University of Texas Heart Institute the repair of the aorta and aortic aneurysms with Dacron grafts. These were actually made by his wife initially out of old parachute material. It's been advanced since then. It's not made of parachute material anymore. It's made of Dacron. But Michael DeBakey and his team at Texas Heart Institute have a lot to be thankful for helping advance vascular surgery. Now we get into the more modern era, we get into Charles Doddern, a radiologist who's now invented balloon angioplasty, where you go in minimally invasive with a needle, shoot contrast into blood vessels and identify blockages from blood clots, etc., or plaque buildup, and he can put balloons in there and stents in there to help treat these blockages, and he helped pioneer this in 1964. Everybody thought he was crazy in 1964, and this is what we all do these days. I did it this morning actually on a patient that had severe blockages in his legs, and we were able to balloon and stent the legs open, the blood vessels in the leg open, to help improve blood flow and heal an ulcer on the leg. And now into the 1990s, and Juan Perotti, surgeon that did the first endograft, stent graft repair for a vascular aneurysm, an aortic aneurysm. Instead of having to open the patient up from the sternum all the way down to the pubic bone, now we go through the blood vessel, deploy a stent across it, and they go home the next day. We can do this now with a lot of percutaneous techniques and just a couple of needle sticks. Did one yesterday, actually, and the lady will go home today. I think she was 83 with a symptomatic aneurysm and did nicely. She's doing great this morning. So again, we talked about a little bit about the anatomy. So we're talking about blood clots. What's the anatomy and what are the important things we need to know? We need to know there are two types of blood vessels. First, it's a circuit. It all starts at the heart. Blood flow leaves the heart, goes down to the arms, goes to the head, goes to the legs, stomach, and all the internal organs too as well. Those are the arteries, and they bring blood flow from the heart. They're very different in structure from the veins, and the veins bring blood flow back to the heart. When we look at them, and this is not a great picture, it doesn't transpose very well here on this screen, but the big thing to realize is that arteries, the ones in the red, are very thick-walled. They're very muscular. They have to be because they help propel and pump that blood out of the heart and get down to the places where it needs to be. They're very high pressure. The veins are not. The veins are very thin-walled. They have a very thin muscular layer, and they have these little things called valves. The veins help bring blood flow back from the extremities back to the heart, and to prevent blood flow from leaking back down into the veins into the feet, they have valves in them so that when you stand up, and we're all standing up, blood flow doesn't just rush down by the flow of gravity back down to the legs. The valves help prevent the blood flow from reaching back down to the feet and us being basically in a puddle of blood down in our feet. So the valves do that. Sometimes they leak, and we'll get into reasons why that happens and what can be a problem from leaky valves in the veins. But that's the anatomy that we need to know. The heart, the arteries bring blood flow from the heart to the extremities, and they're different in structure from the veins, which come back up from the extremities and go to the heart. Different structure, different pathology once we realize that. And again, that's the circulatory system. It's a little busy slide, but again, it just kind of shows the whole circuit again with regards to the heart, and the red stuff are the arteries coming, bringing blood flow down to the feet, and the blue things are the vein coming back and dumping blood back into the heart. And again, just understanding there's different pathology there. So when we look at leg pain, we have to figure out as vascular surgeons, why are patients here, why were they sent here, and what is the issue going on with their leg pain? Are there causes that are of vascular perspective from a blood clot or from vascular insufficiency, plaque buildup, cholesterol buildup, or is it something else completely? Is it nerve root compression, back problems, arthritis, spinal stenosis are very, very common problems, and to be honest, they're the most frequent problems of leg pain that we associate. But people come in all the time, and primary care physicians ask us to see patients and say, hey, is there a blockage, is there a blood clot, is there some type of problem with the circulatory system that's causing this patient's leg pain? And we have to help make a decision as to whether that's the case or not. The things that we really look at are, once the nerve root compression and the back pain and the arthritis and spinal stenosis has been ruled out, we have to make a decision, is there vascular insufficiency, meaning does the heart get enough blood down to the extremities, and are there problems inherently with the blood vessels causing that, from blockages, clots, etc., and then is it venous disease too as well? So again, is it the arteries or is it the veins? And if it's either one of those, what can we do about it? And we'll get into that. Peripheral arterial disease is kind of the most common thing that we deal with. This is sometimes referred to as a blood clot too as well, but it's really more than that. It's actually just a plaque buildup in the arterial wall. This is from years of smoking, high cholesterol, genetic component too as well, and it's what we call the hardening of the blood vessels, although it occasionally is referred to as a blood clot as well. It leads to a reduction in blood flow, but the symptoms are quite variable. It's our job as vascular surgeons to identify and recognize the presence of that, to try to quantify the extent of the disease, come up with a risk factor modification plan, and then establish some type of comprehensive treatment program, which can include just medical therapy and can also include surgical therapies, which is where the bulk of my experience comes into place. Peripheral arterial disease, again, from a symptomatic standpoint, it really ranges, and it ranges from mild to severe. The symptoms can be asymptomatic. You can have peripheral arterial disease and not know it, and it takes specialized tests to figure that out. But it can go from all the way from asymptomatic to pain in a muscle group when walking, the calf or the buttocks, to continuous pain in the foot, to severe ulcerations that aren't healing up because there's a lack of blood flow going to the extremity. And that again, it kind of goes from our mild to severe, from asymptomatic to ulcerations that are limb-threatening or even life-threatening too as well. You're not going to miss the ulcerations when they come into your clinic. You're going to know them very quickly. Non-healing ulcers that have been there for many weeks, many months sometimes, they can be life-threatening and limb-threatening, and it's not very hard to identify those. It's a common problem too as well. As we can see, this is one of our vascular surgery textbooks. As we get older in age, the incidence of peripheral arterial disease increases to where 70 and older, we're talking about 14% of people have the diagnosis of peripheral arterial disease when we get to be 70 and older. So it's a problem that's increasing in incidence. and it's especially common in elderly patients. Our diagnosis comes not only from our history and from the clues that we've talked about beforehand, trying to figure out what system is involved, arteries or veins, but we do the physical examination, and our vascular lab evaluation is absolutely critical. When you come see us, not only do we talk to you and do a physical exam, but virtually every one of our patients gets some type of ultrasound to look at the veins, to look at the arteries too as well, and make a decision as to whether there's a pressure problem, a flow problem. And then if there is, sometimes we even go towards angiography and more invasive techniques to figure out whether there's any blockage. This is one of our routine, and it's almost a different type of vital sign. We call it an ankle brachial index. The blood pressure in the arms is supposed to equal the blood pressure in the legs, and if there's a difference in that, it points to blockages or blood clots or things of that nature in the lower extremity that could be limb or life-threatening that we need to investigate, but it's a common diagnostic tool that we use. Again, if we diagnose peripheral arterial disease and blockages, then we normally will pursue, depending on the symptoms, further imaging, including formal angiography, where we identify blockages that we can treat, again, with balloons or stents. CT as well is also used to help identify blood clots or problems. This is actually an aneurysm with blood clot in it that can be a problem. This one actually is ruptured and needs repair, and we deal with that quite frequently too, as well as one of our diagnostic factors to help treat patients. The treatment initially for peripheral arterial disease is medical therapy, and that's the mainstay of treatment to begin with, including aspirin, control of our other risk factors including heart disease, cerebrovascular disease, or carotid stenosis. Coming off the cigarettes is the biggest thing. It's the most difficult thing to get a patient to do. We talk about it every time, but a lot of times it's pretty amazing to see how addictive nicotine can be, and it's a severe problem in the society. Exercise too as well, and cholesterol management. That's the mainstay of mild peripheral arterial disease or asymptomatic peripheral arterial disease. Once we get to more severe disease, including pain that occurs at all times or ulcers that aren't healing, we get into more traditional surgical treatments. The older ways of treating it are traditional open bypass, where we take a piece of your vein or a prosthetic bypass and bypass above and below the area of blockage to help improve blood flow around that clot and around that blockage. There are different ways now, as we talked about in the history, in the history portion, where we get into endovascular treatments, including minimally invasive ballooning, stenting, or even rotor-rooter devices to help clean out the plaque or the blockages in the lower extremities. And it all really depends on anatomic considerations. As vascular surgeons, we're the only ones in the medical profession that are trained in both of these. There are some people that do just endovascular. Some of the general surgeons just do traditional open bypass, but we're able to comprehensively tailor the plan accordingly to our patients with either open bypass, endovascular management, or both as well. So it really depends on the patient, and we can tailor that to our patients. This just gives you a diagram really of what we can do from traditional open bypasses in the belly to bypass blockage to all of our other different ways, from tying a bypass graft in to different balloons. We have re-entry catheters. We have lots of different tools in our toolbox to help repair blockages and blood clots in the lower extremities that's causing a perfusion problem that can be limb-threatening. This is just a diagram just to show really there are a lot of different options that we can do, and again, we tailor it to a comprehensive plan, not only for risk factor modification, but surgical treatment and endovascular management as needed. Post-operative, once I see you and once you have an operation done by me, you become part of the family. Surveillance is absolutely critical. This is not like getting your gallbladder out, getting your appendix out, where you have it done, you never have to worry about it again. Peripheral arterial disease, venous disease, things of that nature are chronic problems, and they're problems that we have to keep patients under intense surveillance. So you come back and see us on a periodic basis, 6 months, a year, depending on the severity of the disease and what we did. We have to keep you in surveillance because things can happen. Blockages can reoccur, blood clots can reoccur, bypasses can block off, other vessels can block off, and we have to know these things, and it's better to catch it on the early end than it is the late end when there's a severe problem. So we put our patients in an intensive surveillance program after any type of procedure for anything that we do, including vascular lab, history, and physical examination. So again, you do become a part of the Vascular Institute once you have a procedure done by us. And these are just a couple of examples, and we'll fly through these fairly quickly, but it just kind of gives you a before and after of what we do for blockages, blood clots in the lower extremities. And these are some of our examples. This was a gentleman actually from Scotland who couldn't go and play over at St. Andrews because he was having some pain in his leg when he was walking. It was in his calf, and we found this small blockage here. It wasn't very big, but we were able to repair it very nicely with a Roto-Rooter device and a balloon, and he made it out to St. Andrews this year and did just fine walking 18, although he said the weather was bad. These are some of our other blockages too as well. This will just give you just an idea of what we're talking about, more severe with regards to the blockage in the thigh, and a real nice result afterwards. It did put a stent in that one. This one's a little more severe. This is actually a bypass graft that's blocked off. This is the native vessel blocked off all the way through here, and this is the level of the knee. It's hard to see, and it reconstitutes here. So there's a very severe blockage that goes all the way down through here that we were able to repair and have a nice result again afterwards, and put a couple of stents in there and redid the whole flow to the lower extremity. Another severe one too as well. You can already tell that this patient has chronic blockages in the legs just by the fact of how many collaterals you see coming off this deep vessel here in the thigh. So that already means that those are God-given bypasses, that the Lord's helping us trying to get blood flow down to the leg somehow, and so creates these new vessels that come down here and try to feed below the knee to get better blood flow to the lower extremities. But it still needed some work done. You can see that tight blockage there and how ratty it looks through here, and we were able to do a nice job through here to help improve the flow with some stents too as well. Same situation here. This is actually an occlusion. You can see no flow here. We got it reestablished with some nice flow there to the lower extremity. And again, another similar situation here. This one was a unique one. Again, the Lord blessed with some bypasses through here trying to get better blood flow. This is the knee right here. This vessel here is trying to get around to the knee to get to the lower vessels. And these are trying as well, but still having a hard time. And we were able to go through here and salvage things and get better blood flow down below the knee to help improve the symptoms there. Similar situation here, and here too as well. We got a lot of them actually. This is up in the abdomen too as well. This was a blockage. The aorta comes down about the level of your belly button, blocks off, goes to the right leg, goes to the left leg, and you could tell that obviously there was a problem here. Again, natural collaterals trying to come through there. We were able to reline both of these with 2 stents and improve blood flow. This is kind of the midway point. These guys are guilty. They got into the chimney here, had soot all over them, and got in a lot of trouble for this one. They didn't really understand what they had done. They didn't think they were guilty, but they were. And these are these two growing up now, so they're just, it's a lot of fun at the house, a lot of fun. Now we get into we talked about the arterial component. So the blood clots in the arterial component are a little different now than what we talk about the venous component. And the veins return blood flow from the extremities and coming back towards the heart. This is more of our traditional, what we would call blood clot, and what a patient would come into the office and say, hey, I've got a blood clot. This is typically what as vascular surgeons and physicians we think they're talking about. It's usually what we call a deep venous thrombosis, or a deep blood clot to the leg. Most common in the leg veins, and it's very common. 200,000 new cases per year just in the United States alone, and it's high mortality when we talk about a blood clot that breaks off and goes towards the heart. Okay? We call that a pulmonary thromboembolus. We have to make complicated words for everything that we do, but basically that's just a blood clot that normally breaks off from the groin or the pelvis, so the lower extremities, and goes towards the heart. And the problem with that is that once it gets into the heart, it can actually cut off the venous return to the heart, and the patient can go into heart failure, and it can be a very high mortality at that point. So we get very aggressive with any blood clot of the lower extremity veins because of the high mortality when it travels to the lung, and that can be a very complicated problem to deal with and a very severe problem to deal with. So we get very aggressive with these things. And again, you see that it is very common. What are the risk factors for DVT and blood clot in the veins of the lower extremities? Well, number one, age. As we get older in age, there's more of a prevalence of having blood clots. If you've had a previous clot, and I think we've spoken with some patients or family members around here, if you've had one clot, you're more prone to get another clot. That can be for different reasons. There is a genetic predisposition that's a little out of context for this talk, but there is a lot of disorders that are hypercoagulable where patients are more prone to venous clot or blood clots in the lower extremities. And there's a whole host of those that are quite complex, but we deal with those quite a bit. Most of the treatment, again, as we'll talk about, is anticoagulation. But not only from genetics, previous clot, cancer, any type of neoplasm or type of cancerous issue can make patients in a more hypercoagulable state, and so we have to deal with that quite frequently. Anybody who's had surgery, you know everybody gets very aggressive about blood clots during surgery. We put the little squeezers on the legs, or we give you blood shots, usually in the stomach or something like that, to help prevent blood clots, because any immobilization or any surgery puts you, again, at increased risk of developing blood clots and the potential complications that occur from it. So we do everything we can from a prophylactic standpoint to help prevent that. And usually it's either what we call SCD pumps, which are just the compression devices on the calves that we use after surgery if you can't get up and move around, or blood shots that are blood thinner shots that we put usually into the stomach, Lovenox or heparin, different things like that, just to help prevent blood clots in the lower extremities. The best therapy is walking, though. Our patients, if we can get them up and moving around, that's usually the best therapy, but we usually augment it again with the compression hose and the squeezies, as we call them. You'll hear the nurses call them squeezies, or the blood thinner shots too as well. So the surgery issue is a problem. Immobilization, again, just general immobilization. We dealt with this a lot at UAB with our complex trauma patients who are in a car wreck. They have broken bones everywhere. Their pelvis is broken. Their legs are broken. Anything. They're intubated. They're on a breathing machine, critically ill. They can't get up and move around. They're immobilized. They're at higher risk for blood clots, and so we have to do something about that. And that can be a little complex in a trauma patient where you're worried about, hey, I can't give them blood thinners because they've got a bleed on the brain, or there's a bleed in the pelvis from where there's a nasty pelvic fracture. What do you do about that? And we'll touch on that just briefly. Hormone therapy or oral contraceptives also can put you at a hypercoagulable state. That's a little lower on the priority list. The biggest ones really are age, previous clot, cancer. Again, there's a genetic component. And then any surgery or immobilization can be a risk factor for blood clots and deep vein clots. What are the signs and symptoms? Number one, remember, it's asymptomatic too as well. Sometimes you have to have the clinical know-how to realize that that's what's going on, and there are different things that it can be. But the classic symptoms is a triad of pain of the lower extremity, swelling of the lower extremity, or fever. And fever generalized, but also fever or swelling kind of the lower extremity too as well, where it feels kind of hot to the touch. Those are typically the signs of a potential blood clot that usually gets an evaluation, and it usually is an ultrasound at that point. How do we diagnose it? Well, that's what I was just talking about. History and physical. We talk to you and ask you what's going on. Hey, I've been on a plane ride. You know, we talked about that. I've been on a plane ride for a period of time going overseas. All of a sudden I really feel some pain, have a little swelling in my leg. You know, that's pathognomonic for a virtual blood clot, especially if you've been immobilized in a cramped plane seat for quite some time. We start thinking about blood clots and see that quite frequently. Have you just had surgery? Is there a new diagnosis of cancer or something like that? We ask you as well about your family history. History of blood clots in the family? Well, yeah, actually, you know, Aunt Sally has a protein C deficiency or a protein S deficiency, and she's prone to clots. Then we start thinking about these things as to whether that's a potential cause of your leg pain or swelling or fever of the leg or things like that. The history and physical, you know, helps us, but it doesn't definitively give us the diagnosis. So how do we get there? It's usually imaging, and again, in our surveillance program with our imaging and our vascular ultrasound, we use an ultrasound to help diagnose blood clots. Sometimes we use CT scans or MRI scans. Those are a little more down the line, and for more complex blood clots of the lower extremities. And we've touched on this a little bit, but it's a devastating problem. Blood clots are common, and they can be lethal if they travel to the lung, and that's a pulmonary embolism. That's where it breaks off again from the groin. It's usually from the deeper vessels, and it's usually from the bigger vessels. It doesn't happen so much from calf vein, and we see that a lot too as well, where a patient comes in and the primary physician says, hey, you've got a blood clot in the leg. You look with ultrasound and it's really below the knee in the very tiny calf veins. That's a very low probability of a blood clot breaking off. The ones that are more risky and the ones that we worry about are those that are higher up above the knee in the femoral vessels and into the pelvis too as well, where they're in the iliac vessels, and those are larger vessels, bigger clot, and they're more prone to breaking off, and upwards of 20% of those can break off and travel to the lungs. If they travel to the lungs, number one, they can be fatal because they can throw you into heart failure and can shut the heart down, but it also can just cause minimal symptoms such as shortness of breath. Patient gets some chest pain, has some shortness of breath, they have some leg swelling, and you talk to them and, oh, yeah, I had surgery the other day. See it frequently, and you diagnose them, they've got a pulmonary embolism, but they don't have an ultrasound, the ultrasound of the leg doesn't show any blood clot of the leg. Well, that's fairly normal, okay? It's not typical when you have a pulmonary embolism that you can diagnose specifically exactly where it came from. Odds are it came from the lower extremity, but a lot of times you'll get a negative ultrasound of the lower extremity and can't tell exactly where it came from, but odds are it came from there if you have a pulmonary embolism. It's come from the pelvis or the groin vessels, and that's where the blood clot came from. That's the biggest complication that we worry about because it's so lethal when it does happen. There are chronic problems too as well. You have blood clots of the lower extremities that have been there a long time. Let's say you've been treated with blood thinners before, but you still have just this chronic blood clot in the lower extremity. It can cause chronic swelling and what we call chronic venous insufficiency. And this is just where it damages, as we talked about the anatomy, the veins get damaged. And so the valves in the veins get damaged when you have chronic clot in there. And so what happens? Well, the leg swells up because blood flow can't return back towards the heart the way it needs to. And you have chronic swelling of the lower extremities, which can turn eventually into ulcers. And again, that's another severe problem that can eventually be an issue with limb loss when we talk about DVT and complications of the more severe type, and that would be more a chronic problem. The treatment for uncomplicated DVT, so again, patients that come in, have the symptoms of DVT and a symptom of a blood clot, and have the appropriate history for it, and we diagnose it with a CT scan or an ultrasound or whatever. The treatment for uncomplicated DVT is simply anticoagulation, and that's blood thinners. Typically, you're admitted to the hospital depending on the severity of things, and you get started on a blood thinner drip, either Lovenox or heparin, depending on what's going on. And then usually with a Coumadin agent or something else, either Coumadin, Xarelto people are using now. There are different types of agents. That's not so important. But the real thing to remember is you're being treated for about 3 to 6 months for your first episode of a blood clot in the lower extremity veins. Okay? Lifelong if it recurs, because then you start to think about, do you have a hypercoagulable, a genetic disorder or something like that? And we see that quite a bit. Additionally, compression hose. As we talked about, swelling can be a chronic problem after a DVT. We put patients in compression hose to help prevent those symptoms of venous insufficiency with the swelling, with the stasis, ulcers, and things that can be a problem afterwards. So we do recommend compression hose. That used to not be the case, and historically speaking, when a patient had a blood clot of the leg, we didn't recommend compression because everybody was worried about it breaking off and traveling to the lung. And so what they wanted you to do was to stay in bed historically and no compression on the legs. Well, that kind of dogma has changed completely. And so if a patient does have a DVT, we are typically okay with doing compression hose because there's a very low risk of that breaking off, and we do want them up and active and on their feet again as soon as possible. So that's kind of one of the interesting things when you look at the history of vascular surgery, how that's changed significantly over time. We don't recommend sedentary lifestyle in the hospital anymore. Everybody needs to be up and moving around. So I think patients get mad at us sometimes, but we want you up on your feet to help prevent these things. Complicated DVT, more difficult to treat, and this can be, this is another lecture in of itself, but it can be a limb-threatening or even a life-threatening problem. If you get your clot burden so high in the lower extremity or in the groin that causes massive swelling of the lower extremity and blood thinners alone are not working, it occasionally can cause a problem where the swelling is so bad in the lower extremity that it can cut off blood flow coming to the foot. So if you think about that, again, there are two systems, blood flow coming down to the arteries and the veins come back. Sometimes if that clot burden is so severe, it can cut off the blood flow coming to the foot, and that's a severe problem. I've seen that a few times in my life. We have a special name for it again. It's a weird name, as everything is. It's called phlegmasia. And I didn't write it down. I should have. I can spell it out later. But phlegmasia, again, is where the vein clot is so severe of the lower extremity that it cuts off, the swelling cuts off the lower extremity circulation with blood flow coming to the foot. Those patients are very sick very quickly. And I saw my last one about 6 months ago. Severe pain in the lower extremity, severe swelling. It can eventually turn to gangrene of the foot or gangrene of the leg and turn into a limb loss situation where you're having to amputate. We have to get very aggressive very quickly with these patients. We use clot busters that a lot of patients have with strokes or things like that. There are different types of agents we can use to help try to bust that clot up. And we go in and we try to mechanically rotor-rooter to clear that clot out, and then use a combination of the mechanical rotor-rooter, the clot buster to help clean it out, and then they get put on blood thinners, and usually I recommend lifelong if they've had an episode like this. Compression hose too as well, and continued surveillance. Again, you're part of the family at that point and you see us quite frequently. But it's a difficult problem. We spoke briefly of the trauma patients, and this is where it warrants discussion. Some of you might have heard about filters. IVC filters, that's abbreviation inferior vena cava filter. So when we look back at our anatomy, the veins come up from the groin, and where they meet behind the belly button is called the inferior vena cava, and that spills blood back into the heart, okay? So the inferior vena cava is where the confluence of the vessels come in from both of the legs. Sometimes if we have blood clots of the lower extremities and we can't put a patient on blood thinners, we're unprotected. So you've got a blood clot in the lower extremity. You need blood thinners because you don't want to risk that clot breaking off, going towards the lung and causing a problem, but you can't because there are other reasons, and there are a lot of different reasons. We have patients we put on blood thinners and they bleed. They have a stomach ulcer that bleeds and they start passing blood through their stool or something like that, throwing up blood. Patients that have had either some type of head trauma and have a head bleed and they're too risky to put on blood thinners. Sometimes we're caught between a rock and a hard place because the treatment for a blood clot is the blood thinner, but we can't use it, so what do? Well, the filter is just a mechanical basket that helps us to catch blood clot coming from the lower extremities. Okay, and we put it in. There's a diagram of the vena cava. I knew I had one in there somewhere. And again, the blood flow comes back up from here, and we need a filter that looks like a little wire basket that we put in there that helps prevent blood clot from migrating up and traveling towards the heart and towards the lungs and causing a severe problem. It's a good thing. It helps us in a bind. Now, it's not the best thing because the best treatment is the blood thinner. So there are times we can put in temporary filters, and if we can get a patient back on blood thinner, we'll do that and take this filter out. This one, as you can see, has a little hook on it, so we can actually take some of these things out. The older models, you cannot. Some of the newer models we can take out, and there's usually a time frame as to how long it is before we can get out, and we can get into that. That's another discussion, too, as well. So what is one of the chronic complications after blood clot? And this is kind of the last portion, then we'll take questions. Venous insufficiency. We talked about the different complications, and we've talked about pretty extensively blood clot breaking off, going to the heart and to the lungs and causing a catastrophic problem. We talked about the chronic swelling that can render a limb sufficient or insufficient with venous insufficiency. It damages the valves. You have chronic swelling of the lower extremity. And it can cause varicose veins and venous insufficiency, which is an extremely common problem, especially with varicose veins, 5 to 30% of most adults. Chronic lower extremity blood clots, or also just idiopathic or just occurring on their own, can result in varicose veins, kind of run-of-the-mill varicose veins. And we won't get too much into this, but again, this can be a problem too as well with pain, swelling, heavy, tired, and aching legs, infection, and ulcers. And again, the risk factors, as we talked about, blood clots is a significant risk factor for this, but again, smoking, lack of exercise, obesity, family history, and high blood pressure, standing for long periods of time too as well, can be an issue with that. As we talked about in the veins, they're different in structure. Thin-walled, they have valves in it so that when you stand up, blood flow doesn't push back down to the feet and you're standing in a pool of blood. With patients that have had previous blood clots or patients that have venous insufficiency, varicose veins are caused by blood flow that leaks back through these valves that are damaged. And blood clots that are chronic in these lower extremity veins can render these valves incompetent, meaning blood flow leaks back through there. And that's why you have the problems with varicose veins after a blood clot or problems with venous insufficiency afterwards. Again, we kind of got into this, not too much to talk with about there. The differential, it's blood clots is a major cause of that. There are other different causes as well. The diagnosis is fairly straightforward again. History and physical, we talk to you, we look at you, we examine you, and then we send you to the vascular lab and you get an ultrasound again. We look for blood clots again, and then we look for the leakiness in the veins. Okay? What can we do? Again, the mainstay of therapy is compression. We do compression hose to help improve the blood flow back up from the legs towards the heart. We can do other additional things with injection or sclerotherapy to take care of the unsightly veins. We ablate with a laser fiber the culprit veins too as well. If there's leakiness, we can ablate the veins to help improve the circulation and improve your symptoms of pain or swelling of the lower extremities. And then we also take out the big, large, ropey varicose veins too as well that might be bulging or causing problems. We can just pull those out in the office, and we do it minimally invasive in our office under some light sedation. It's less traumatic as it was with traditional stripping. This is, again, I like the history of this stuff. The traditional stripping was quite a morbid procedure with significant amounts of nerve damage where you go in below and above, tie off the vein, and then just rip it out of the leg. And it's quite an extensive procedure. And again, there's a lot of blood vessels run with nerves, and so when you pull a vessel out, your nerve's coming with it. And so there was a lot of trauma associated with those procedures, so people don't like them as much. We have good results, though, afterwards. Again, patients that have blood clots or varicose veins before and after treatment, and we help them, and it helps their lifestyle, too, as well, especially patients that are on their feet for significant periods of time. That's a quick run-through with vascular surgery, and I am more than happy to answer any other questions with blood clots and other peripheral arterial symptoms that we can help with. Thank you all very much.